Okay, so we're changing the schedule. Anyway, my talk is geared towards students and clinicians interested in improving healthcare through research. So I have some conflicts of interest that are not relevant to this talk. The talk is in English because of international audience, but I'll try to speak slower. So briefly touch on history of clinical research, discuss scientific method, how to ask good questions, which is the most important part of research, and then at the end touch a little bit about publishing the results. Probably one of the first experimental or quasi-experimental studies in medicine has been done by Jim Lind three centuries ago, when he divided and in a search for a cause and cure of scorbut, which was plaguing the Navy at that time, he treated prophylactically sailors with vinegar, diluted sulfuric acid, cider, seawater, oranges, and lemon. And in a small study have come to a breakthrough that have saved a lot of lives and disabilities at the time. And it was one of the first publications related to clinical research. Our neighbor up north from Bosnia in Hungary, Dr. Semmelweis, I hope you as a students have learned about him, have done one of the first health services research or clinical practice research. He studied puerperal sepsis in Vienna, and that was one of the biggest causes of maternal mortality for all the way until 20th century. And his boss didn't really like it. Semmelweis noted that the sepsis rate was 3 times higher in Division 1 than Division 2 of labor hospitals in Vienna. And everything was identical except that the medical students worked in Division 1, while only midwives worked in Division 2. What was interesting, that medical students at that time also performed autopsies. This is mid-19th century. There is absolutely no idea, it was before Pasteur, no idea about microorganisms as potential causes of diseases. He did one of the first interrupted time series, which is kind of a gold standard for looking things over time and for quality improvement. And when there is harm is involved, where you cannot really do the real clinical experiment. And by the intervention with the hand washing, at that time with the students, the mortality rate dropped quite dramatically from 18% to 1%. As you could see here, there's random variation day to day, week to week, and month to month. But then there's a clear decline, which one would say is causal and not just temporal trends by the hand washing. Unfortunately, his boss didn't believe that. He was fired. He moved back to Budapest, Hungary, to his home, where he repeated the experiment with the same result. His paper about understanding and prevention of puerperal sepsis was rejected by Vienna Medical Journal, and he had to pay to get his work published, which is interesting nowadays. He died in a mental institution saying, "Beware of doctors, else I shall kill you." Today, hand washing is by far the single most important method of preventing the spread of infection, particularly in hospitalized patients, at Mayo Clinic as well. Let's talk about scientific method. So first, if anyone is interested to learn deeper about clinical research and how to think in a way of research, I suggest you look up Peter Medawar. Thanks to him, he was a English, actually Brazilian English researcher who invented and discovered immune tolerance, allowing us to do transplant, but he was also a theorist of science. And there is so-called medawar zone where you could see that the question has to be posed in a way that it can be answered, that the research is very practical manner. Having a very simple research question, such as glucose, or oxygenation target on a ventilator of 95% versus 90%, simple question, but no new knowledge. Or having a very complicated question of multivariate analysis of causes of multi-organ failure, far to the right, would also have no new knowledge. So you have to have a sweet spot where the answer is, where the question is answered. First you formulate the problem, make a hypothesis, you need to define rejection criteria, make a prediction, perform the experiment, and that way test the hypothesis. So this is a explanation on just how you do scientific model method for anything, but very applicable to clinical research. So you have, in the US, you have pennies and nickels. These are little coins. Some are copper and smaller, and some are silver and bigger. And you can have a study problem of having some coins in front of you, and you want to make a hypothesis what the type of coin it is. And you can say, okay, let's see, I think it's a penny. And you have to make a rejection criteria by color or size. So if it is a penny, the color would have to be copper and size would be 1.9 centimeters. If it is different than that, we will not be able to accept that. We have to reject that hypothesis. So you take a sample coin and you find on your experiment that the coin is actually silver and the size is like higher, 2.4 centimeters. So that shouldn't be a penny. So you have a rejection criteria, and the conclusion is that it's not a pair. And then you reformulate hypothesis, make another prediction. There's no more complicated than this, but we are rarely following it religiously as we should. It is an ongoing and iterative process. So you make observation, whatever you see in nature, like Dr. Semmelweis did. Then you think of the question, why do you think this occurs? You formulate the hypothesis. What could be that? Develop a testable prediction, the key part. If my hypothesis is correct, then I expect A, B, and C. You gather data to validate or invalidate these predictions. Based on the result, you develop the new general theories, or you go back and refine and alter and expand or reject your hypothesis. And you do it many, many times to get to the truth ever a little bit closer. So it's not, the problem is that you're never fully to the truth. You always approximate closer and closer to make a practical recommendation for doctors and nurses taking care of sick people. As this is attributed to Albert Einstein, you may have heard it. He said, if I had 1 hour to solve the problem that the world depends on, I would spend 55 minutes defining the problem and only 5 minutes finding the solution. And unfortunately, we never do that. We jump on big 10,000 patients randomized studies without having defined the problem in a way that is answerable and that will give appropriate new knowledge. How would you find out if the research is going to be useful? So first, you want to make sure it's a big problem. Have you looked at all the previously assessed information? Is there a need for the new study? Is the study going to be informative? Does it reflect real life? If you do the study, will it be applicable? Or if it is not applicable, does it matter? It has to be patient-centered. That's the key. You have to balance the resources that you will use. Can this research be done in a time frame you say? And then, very importantly, are the methods, data analysis verifiable and unbiased so that someone else using the same methods will be able to come with a similar results. There's a nice acronym: FINER, feasible, interesting, novel, ethical, relevant. Feasibility, that means what kind of information do you need to answer the question? what patient population, what is the exposure or intervention, what are the outcomes, what information you have available or it's easy to collect, and what resources you need to obtain those data. Feasibility by no means is using invalid methods because that's the best that can be done. What is important is that you do literature search and define so-called knowledge gaps. So first, is the problem significant? What is currently known? So you have to review the literature. You have to be an expert before you start your study. What is not known about the topic? What are the knowledge gaps? And then how will your study going to fill or minimize this knowledge gap with the new data collection and analysis? If you cannot explain this, it's not research. It is research in English, it's not search. You have to look for what other people have done before you. So you have great databases, which are publicly available, like PubMed. You do a literature search. If not previously done, you look and do yourself a systematic review, which is a kind of a research, secondary research in summarizing the previous data, often with the help of a medical librarian. And then you often have to do qualitative research. You interview and survey stakeholders, that means like nurses and physicians working with a particular problem, and experts in the field to see what are the key knowledge gaps that you could improve upon. Is the research going to be ethically acceptable? You have to look from two different aspects. One is if it is therapeutic procedures where the patient may be benefit, even the patient enrolled in the study. And for that, you have to have a clinical equipoise. It should be consistent with competent care, and the risks are reasonable in relation to potential benefit to the students. On the other hand, for non-therapeutic procedures, such as surveying the patients, measuring things of them, bothering them by doing ultrasounds 5 times a day, whatever it is, first you look, is it a vulnerable population? And then if it is, you have to make sure that the risk or burden is not more than minor increase over the minimal one. If both therapeutic and non-therapeutic procedures pass, then the research is ethically acceptable. And in all countries, there are ethics review boards that you have to obtain before you can perform any research on humans. Specific aims is choosing the overall research question by identifying who, define the population, where, the setting, when, the time of analysis, prospective or retrospective. It means not like looking, in relation to data, not if it was collected 10 years ago. You can have a prospective study on historical data as well. What variables are interested and how are you going to do it? What tools are you going to be? The tools have to be valid. So appropriate tool for measuring what is intended to measure. So scale for a weight and meter for the height. And reliable. It has to be reproducible. You have to have a good reliability. If the two different people or different time perform the same measurement, the results should be similar. So the tools have to be calibrated. A little bit about cause and effects. Causality and association are often mixed, and especially in nutrition studies, in large epidemiologic studies, causing a lot of harm with big data and AI. It's still a problem. This ridiculous example is showing the perfect correlation between the US spending on science and technology and suicides by hanging, and obviously it has nothing to do with it. It's just a population growth. Hill's criteria of causation have start with the strength, the effect size, consistently, reproducibility on more than one experiment. It has to be specific with no other likely explanation. Temporality, the cause has to occur before the effect. Often we looked at the effect-cause relationship, which is detrimental. Biological gradient, so the greater exposure, greater effect. Coherence, so between clinical and laboratory or model findings. Analogy, the effect of similar factors in different fields. And then finally, as a gold standard, experimental evidence whenever you can do it, which is done by randomization. Often before you would start, you need to build directed acyclic graphs, starting to what is known potentially as causes and effects in certain physiological realm, and then you try to fit your question within this framework, knowing what is a cause and what comes before the other. The descriptive studies that you usually do in preparation for research to find out the frequency and distribution in time, place, or person, to see how often something happens, so population survey. But the real studies are either analytical. They can be either observational, where you look for causal hypothesis with uncontrolled assignment. You can only do that if there is a natural experiment. For example, if there was something that has happened that you could take advantage of, like Dr. Semmelweis using the new method of hand washing, or there is Dr. Begovic and I don't agree, and he always likes to prone the patients, and I sometimes don't prone the patients, and then there is a natural experiment that we could take advantage of. Often there is comparison between apples and oranges, so that there is no natural experiment, there is no point of doing analytic observational study. In that case, you have to do an experimental study where you test causal hypothesis by randomly assigning patients to one or more exposures or interventions. This is the meat and potato of my talk. If you want to remember anything or to take a photo of the slide, take this one. This is a template for an answerable clinical research question. If you cannot have your research question formulated in this format, is not research. As acronym is PICO and RAM. So P is patients or population that you are wanting to study. So patients admitted to Mostar, hospital with COVID pneumonia. Does exposure or intervention? So does exposure to hot weather or like not having air conditioning versus comparison? Having air conditioning improve or worsen outcome? Have to spell it out well. So for each of these P, CO, you have to have clarifications that they are measured well. So patient and population have to be representative of the population you are interested in. Exposure and intervention should be allocated appropriately. So at random, if possible, or should not be as much as possible, should be similar groups with regards to co-exposures, known and unknown. Sometimes you can do it with statistical analysis. Often it is by thinking before, is there a natural experiment, or the differences are just because different patient populations. So rich people get to air-conditioned room, poor people go to non-air-conditioned room. You cannot compare that, for example. Both exposure and comparison have to be measured well with valid and reliable measures. That means if you are measuring the outcome, it has to be outcome of interest. So if it is survival, that means how many days or weeks the patient will live. You make sure that you know the date of that no patients are lost to follow-up. If you're looking for development, let's say of ARDS, it's very difficult because Dr. Malhotra and Dr. Begovic and I cannot agree what the ARDS is and what is not. So it's not a reliable measure. So you cannot use this really as an outcome unless you do it in duplicate with TUPE. Very briefly about data collection. There are free online available tools such as RedCap and many others where you could do online data collection, which allows you to de-identify data, to have controls, not to put stupid things in, with some range to prevent errors, with range checks for numbers so that you cannot enter the impossible number by mistake, making the data more structured and easy to analyze. With regards to statistics, I'm not going to go much, but you start with a descriptive statistic. Measuring in medicine, it's continuous. Variables are always skewed, so it's median and range, very rarely mean and standard deviation, and then categorical data are measured as yes, no, or numbers or percentages. Comparison is usually done in a univariate manner. That means raw, unadjusted, again, because of skewed data or not normally distributed by Wilcoxon test, and for the nominal variables by chi-square and with small samples Fisher test. Always you have to try to adjust for any potential, especially not in uncontrolled studies, and sometimes in controlled studies for potential differences at baseline with using logistic and linear regression and some more advanced machine learning models nowadays. There is also free software. It requires a little bit of coding, but it's available to everyone, called R. There are others as well. Finally, reporting a research paper. It's relatively simple once you have a good question. So introduction should be only 4 paragraphs. Why bother? So the one sentence of why the problem is significant. 1 paragraph of what is it known, what other studies have shown. 1 paragraph what is not known, defining the knowledge gap. Whatever is not yet evaluated or there are conflicting results. And then you, as an answer to the knowledge gap, you explain in 1 paragraph the goal of your study. How will your study help narrow the gap? The methods is a detailed recipe that's so that someone else can replicate the study. Who, what patient population, inclusion and exclusion criteria, design, case control, cohort experimental, exposure intervention, detailed definition, very specific definitions, co-exposure and co-interventions as well, so-called confounders, outcomes, again, detailed definition, statistical methodology, how did you come up with the number of patients, what analytical methods, sensitivity analysis for any assumptions, etc. Results, you start with characteristics of enrolled patients, so-called figure 1 or consort diagram, where you described how you get to the final sample, how you and why excluded any patient from the full catchment until the final sample. Table 1 provides the baseline characteristics before the exposure or intervention according to the groups to make sure so that everyone can see if the patients were comparable in those 2 groups, so there were some systematic differences that could explain different results. Then the effect you describe usually in a table or 2 or 3 tables. The effect of exposure or intervention are primary, secondary, and exploratory outcomes. Univariate, as we discussed, unadjusted, and multivariate or adjusted. You finish with sensitivity analysis, testing the subgroups, post-hoc exploratory analysis, and different assumptions. Discussion, again, simple. In 1 paragraph, you summarize 1, 2, or 3 main findings. You don't need to repeat the numbers, just summarize, interpret the findings. Then discuss each of the main findings in a separate paragraph, comparing it and contrasting it with previous studies. You have a next paragraph is describing the strengths and limitations of your study. Finally, the last paragraph is implications for clinical practice and future research. And the conclusion is usually just rephrasing the first paragraph. They have excellent reporting guidelines. They have a QR code that you should capture and go and learn, and never publish a paper without carefully looking for each study design, how would you report it. That way, it will help you publish your paper and make a difference in at least some patient lives in the future. Thank you very much for the privilege to talk to you today, and I would be happy to answer any questions.